So we're getting ready to wrap up this conference, but we still have our last speaker and our summit director. So let's give a round of applause to all the speakers so we can somehow also wake up. So just a brief introduction, Dr. Luiz Rivera is a regenerative, anti-aging, and longevity medicine. Martinez Rivera. Wait. So I'm trying to speed it up, and this is what happened. Luis Martinez Rivera is a regenerative, anti-aging, and longevity medicine specialist. He obtained his medical degree at the Ponce School of Medicine and completed his residency at the University of Pennsylvania. He's certified in stem cells in cancer. His fellowship trained in clinical lipidology. He's also consultant, clinical researcher, advisor to several companies and healthcare organizations. He is co-founder of the Clinical Peptide Society and also co-founder of Caribbean Anti-Aging Medicine Association, CAMAS, and our scientific medical director for this summit. So join me in welcoming Dr. Martinez Rivera.
Awesome. Thank you, Wendy. Can you guys hear me? Is this on?
Yes.
Yeah, good. All righty. So I have the honor of giving the last talk on a Saturday after more than 8 hours of lectures. That's going to be a challenge for me. I have a lot of information, and honestly, I'll go a bit fast. So we really probably can't cover everything in 30, 45 minutes, unless you guys want to stay here till 8 or 9 p.m. A couple of things. I wanted to, you've heard today peptides, nutrigenomics, hormones. Well, peptides a bit. Hormones, hyperbarics, mitochondrial functioning, correction. So you heard a lot of things, right? And I still, there's a lot more that is involved in what's longevity and anti-aging medicine. And I wanted to just briefly cover a bit of that, briefly, okay? So a couple of things. Objective-wise, let's talk about what anti-aging and longevity medicine is. Let's detail or discuss a bit about aging as a disease, detail some diagnostic options for aging, and discuss some current and up-and-coming therapeutic options. So first of all, what is anti-aging medicine, right? It's an evolving medical specialty. It involves using proactive, evidence-based interventions to address aging and its complications, right? There's a bit of an overlap between anti-aging medicine, longevity medicine, age management medicine. You're going to be hearing a lot of these terms. And again, they're usually, for the most part, they can be almost synonymous, right? What's really important when we're talking about anti-aging medicine is that we need to learn what the hallmarks of aging are. And we need to address those hallmarks of aging in our interventions with patients. We need to be able to measure them and address them. So that's really important there. I get this question a lot. Longevity medicine and anti-aging medicine, are they the same, right? You're going to hear some people talk about longevity medicine. You're going to hear some people talk about anti-aging medicine. They're essentially the same if we go down to the science. The difference, why the distinctive terms? So what happened was historically, when they started talking or when they coined the term anti-aging medicine, historically people would associate it, and even now they still associate it with aesthetics. Obviously, the hormone replacement therapy and some of the more basic stuff. And a lot of members of the scientific community, the researchers at the universities and elsewhere, they didn't want to be associated with that concept of anti-aging because they felt that scientifically, this is all, just aesthetics and Botox and all that stuff. So in various circles, they started talking and say, let's call what we do longevity medicine. But they're essentially, if you go down to the science, they're really essentially the same. We're looking at aging, we're looking at aging as a disease, which the scientific consensus has been building to consider aging a disease. I consider aging a disease. And there's clinical trials underway, and there's multiple universities, many biotech companies. Everyone is saying now, hey, what do we do? We need to cure aging. We need to address aging. We need to stop it, reverse it. And we know that there's multiple factors that contribute to aging, right? So this is the paradigm. Aging is a common factor for basically most if not all of the chronic degenerative diseases that we have. Why do we, as we age, we develop arthritis, we develop cancer, we develop heart disease, metabolic dysfunction, all of this, it happens as part of that aging process. Now, I mentioned the hallmarks of aging. So if you're really getting involved in the field of anti-aging medicine, you need to learn a bit about what the hallmarks of aging are. I'm just curious, is anyone familiar with the term, the hallmarks of aging? Okay, so the hallmarks of aging, it's basically standardizing or systematizing the aging process. Originally, 9 processes were described in relationship to aging. Now, there's 3 criteria to have something detailed as a hallmark of aging. It's a process that happens under normal aging. It speeds up aging if worsened. And if it can reverse some aspect of aging if we abolish it. Those are the 3 criteria to define if something is a hallmark of aging. Understanding these criteria, we can specifically measure and address therapeutic interventions for aging, right? So these were the original hallmarks of aging. Genomic instability, telomere attrition, epigenetic alterations, loss of proteostasis, deregulated nutrient sensing, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, and altered intercellular communication. These were the 9 original processes that, again, the scientific community said, hey, if we can modify these, if we can alter these, we can impact aging. As the science evolved, and the science is always evolving, there's been a few more hallmarks of aging that have been added to this. Compromised autophagy, altered microbiome disturbance, splicing dysregulation. So there's a few more factors that, from a scientific perspective, we know that are being altered or are altering the aging process. So again, this serves, I think, as a unifying factor for what aging is and what we can do to alter aging. And I think this morning I asked a question, who wants to age? And we have one person that wants to age there. I think she's just a bit tired. It's not her fault. She needs some maybe wine or coffee or both. So nobody wants to age. I mean, and nowadays we know that we can really impact this, right? So the first thing, if we're gonna practice anti-aging medicine, we need to be able to assess aging. Where do we start? How do we start? Well, obviously, we have to measure biological age. That's the basis there. Every one of you that wants to enter longevity medicine, anti-aging medicine, should have some tool to measure biological age. There's various tools. There's no perfect tool, but there's multiple things that we can do. What are the requirements for the clinical assessment and the lab assessment for biological age? First of all, it should measure one of the hallmarks of aging. If you're not measuring one of the hallmarks of aging, if you're measuring, I don't know, 100-meter sprint, that might not be the best tool to address biological age, right? It should be able to differentiate chronological versus biological age. It should have reproducible results. Ideally peer-reviewed and clinically available. Those are the requirements for an adequate test to assess biological age, right? And again, we see in the field a lot of new stuff coming out. Some of it is still experimental. So when we incorporate some of these tests, we need to try to make sure they're as validated and as reproducible as possible, okay? There's multiple tests that can be used to measure aging, okay? The more common ones right now, I have 3, maybe more, but I have 3 that I think you should know about. One is telomere length, the other one is cellular senescence, and the other one is epigenetic testing. Okay? Are any of you measuring any of these things right now? Telomere length, cellular senescence, epigenetic testing. So let's go a little bit more into these, right? Telomeres. So telomeres are tandem repeats of nucleotides at the end of our chromosomes, right? They protect our DNA. They help maintain genomic stability. As our cells divide, the telomeres get shorter and shorter and shorter. The telomeres with multiple divisions reach a point where they're so unstable, the cell cannot divide anymore. We used to talk about Hayflick limit, maximum limit for cellular division, right? And this happens because, again, the telomeres are just critically short, and if the cell keeps dividing, we risk genomic instability. That can all break apart. So that's one thing that's happening there, okay? We know that A, we can measure telomeres, and B, we know there's an enzyme called telomerase that can repair telomeres. It can actually make them longer, right? So we have lab tests available, the telomere length test. It's a clinically available test. It can measure leukocyte telomere length. So basically, it can tell you how long or how short your telomeres are. And that is compared with population, standard population. And from there, you can derive mean, median, and natural distribution in curves and see where you are with respect to everyone else at that age, right? So you can have, say, 40 years chronologically, and your telomeres may say, hey, you're biologically 30, or you're biologically 50, right? And we know that there's benefits to telomere length. It's been correlated with multiple. There's been studies on brain aging and telomere length. There was a recent study showing shorter telomere lengths increasing the risk for dementia, Alzheimer's type. So again, we know that it is a valid tool, and it's a tool that can be used to determine or help determine biological age. There's a sample report there, right? So basically you get that and you get a median telomere length test. It can show you where you're at, and it can give you an idea as to age-wise, chronologically, where you would be, right? And it can get a bit more sophisticated. We can look at proportionally critically short telomeres, longer telomeres. So it gets pretty sophisticated, right? But at least it's a good starting point if you want to do that, and you can tell your patients, hey, biologically, this is where you stand right now, right? Now, another thing we can do is cellular senescence, okay? Why test for cellular senescence? So we know that it's another hallmark of aging. As we age, we get these old cells, call them zombie cells, senescent cells. And these cells, they stop dividing, and they're just really hanging around. And the problem is they're not only hanging around, they're secreting inflammatory cytokines. And not only are they secreting inflammatory cytokines, they are recruiting other cells into their senescent party. So like, hey, come hang with us. They all become zombie cells. They're not doing anything. They're not dividing. They're not working. And that leads to tissue and organ dysfunction. Right? There's a lot of changes in senescent cells. Cell surface markers change, organelles change, lysosomes, structural components. So we can tell what cells are normal cells and what cells are senescent cells. Right? There's multiple biomarkers for that we can look at when testing for senescence. One of the most common ones is SAB-GAL. B-GAL is a marker for lysosomal hyperactivation. And that's a really good, reliable marker for what's happening, right? So B-GAL is a hydrolase enzyme that catalyzes the hydrolysis of certain sugars in the cell. So basically the whole waste system of the cell. Ideally, your cells should be able to secrete all that waste. It's what I call cellular housekeeping, right? So when we test for that, we can look at elevated levels versus normal levels, and these elevated levels can correlate with senescent cells. Right? So you can get a report and you can see where these senescent cells are, and you can tell your patient where they are. This can help us, and I'm going to talk a bit more about that. This can help us when determining if we want to use senolytics or senotherapeutics with patients. The other test is epigenetic testing. And this has been probably on the spotlight a lot. It's become very popular to use epigenetic testing. DNA methylation, and again, epigenetics, there's a lot of information, we don't have much time, but basically, epigenetics really dictates whether or not our DNA is expressed. So before we would say, well, if you have certain genes, you're screwed. You're not going to be able to do much. But as we learn more about the science, we know that epigenetics can dictate if certain genes are activated or if they are shut down or silenced, right? And we have, I like to say, the genes are the light bulb, right? Epigenetics is a switch. So bad genes do not necessarily condemn you to a life of unhealthiness. You can still modify your health, your gene expression with epigenetics. And we have, right, certain tests that can measure methylation patterns in these cells. And based on those methylation patterns, we can really precisely tell biological age. And not only biological age, but this is really interesting. There's multiple algorithms that have been presented, multiple researchers looking at epigenetic testing, what they call epigenetic clocks. And again, this is really interesting. It keeps getting updated, but as we incorporate this data, we can get a lot of useful information, not only biological age, but for example, if we look at cancer, right? For each 1 year increase in difference between chronological age and epigenetic age, which would be your bona fide biological age, there was a 6% increase in developing cancer within 3 years and a 17% increase in dying of cancer within the next 5 years. That is very powerful. And if you can test someone and identify that and give them that information, that can be life-changing for a person. They've looked at epigenetics and death. For every change, delta change in epigenetic age versus biological age, the alterations in these methylation patterns, they can look at the increases, the probability of death within the next 5 years, 10 years, and it's all based on your epigenetic test, right? Epigenetic age. And the good thing about epigenetics is that we can modify that. So when we have a patient and we do an epigenetic test and we see, where you're at, hey, epigenetically, you're at an elevated age compared to your chronological age, we can tell these patients, hey, you have a higher risk of cancer and mortality within the next 5 years. So why is this all important? Because again, if we're going to integrate interventions, therapeutic longevity interventions, we need measurements. You cannot impact what you don't measure. So we need all these different tests so that we can see when we're doing the different treatments where this patient is. If we're giving senolytics, are we reducing senescent cell burden? If we're using, optimizing nutrition, lifestyle changes, is that really improving that patient's telomere length or epigenetic age, right? So all this is very important, specifically with what we do. What do longevity anti-aging medicine practitioners do? So again, the fundamentals, the lifestyle, the nutrition, the hormones, the IVs, then we start getting into the peptides, microbiome, then we start getting into other options. And again, this is what I wanted to summarize for you. We can't go into everything, but I think these are some things that you need to know about because we need to really dig deep and define the specialty. Senolytics and senotherapeutics, right? I mentioned briefly senescent cells. And again, the field is rapidly evolving. If we knock out these bad cells, these senescent cells, we can decrease inflammation, we can improve epigenetic age, we can improve telomere length. And we have different options there, right? It's become quite quite detailed, quite sophisticated, because we talk about senolytics, senostatics. These are different types of senotherapeutics. So there's a whole field right now addressing old senescent cells. We have some medications and supplements that can kill off some of these cells. We have other drugs or other treatments that can just basically keep them quiet or at bay, right? So that's senostatics. But all of them fall under this broad category, which belongs to us longevity anti-aging medicine practitioners, that we're looking at addressing senescent cells, right? Some of the benefits of using senolytics, senotherapeutics, inflammation goes down. You improve cell and tissue organ functioning. You improve immune response. If you're not aware of this, you should check on the concept of immunosenescence. As we age, our immune system also gets old. It cannot fight off infection, or even it cannot eliminate bad cells the way it used to. That's why we get increased cancer as we age. That's why we get chronic unresolved infections. Our immune system is senescent. Using senolytics can enhance regenerative capacity. So there's many benefits to doing this, right? Some of the compounds that have senolytic potential, dasatinib, a chemotherapeutic, quercetin, a nutraceutical, fisetin, another nutraceutical, gluteolin, another one, curcumin. Then we have things like FOXO4, a peptide. And then we have other medications. So what's interesting in this field is there's many products, both natural and synthetic, that have shown a capacity to kill off some of these zombie cells. And we have some interesting data on the combinations. One of the most well-known combinations right now is the dasatinib quercetin. Metformin is, I wanted to include it here because, it's a well-known drug. Everyone here knows what metformin is, used for diabetes. But now we know that metformin can also have an impact on aging, cancer. It can modulate AMPK, which is one of the major pathways, downstream mTOR inhibition. And definitely there's evidence supporting early pre-diabetic use and even use in healthy patients. There's a trial, TAME trial. Some of you may have heard of it. Dr. Neil Barzilai, I think he's out of Einstein, is that? I can't remember. He's out of New York. He's based out of New York. And he's running this large trial on the use of metformin to impact and treat age-related conditions. And what's interesting about this trial is that and I'm confident it should show benefits, if and when it shows benefits, the FDA may finally officially recognize an intervention to treat aging. Now, if that happens, that would be huge. That would change the way that we prescribe some of these medications for populations. You won't necessarily have to be a diabetic or even a pre-diabetic to start metformin. I have a lot of healthy patients that are on metformin right now. Low dose metformin, we combine it with other supplements and drugs for the purpose of improving longevity. Rapamycin. Rapamycin is another big one in the longevity field. It's an mTOR inhibitor. It's already an approved drug, transplant rejection. It's used to coat coronary stents. In the higher doses, it's been shown to be immunosuppressive, anti-proliferative, but it can have also, at lower doses, an immunostimulatory effect. And the thing with rapamycin is rapamycin inhibits what we call geroconversion. Geroconversion is when a healthy cell, the quiescent silent cell, becomes recruited into what we call senescence. Rapamycin can block that, can avoid that conversion. And it's really one of the more tested and more promising interventions for longevity aging. So it inhibits abnormal cell proliferation. It blocks the conversion to senescence. It keeps cells in more of a standby quiet mode, right? Clinically, there's different dosage. I use a lot of microdosing. I have a combination therapy where I microdose rapamycin. But it's been studied, 2 to 6 milligrams a week. Some protocols call for 1 weekly dose or a few times a week. So there's different ways to administer rapamycin for longevity, but it definitely helps. This is a slide. Mice, untreated mice treated with senolytics, an increased lifespan of 27%. And as you can see, the senolytic treated mice looks a lot better. So we know from lab, from research studies and whatnot, that senolytics can help. Now, I was talking about DQ, the dasatinib quercetin combination. The dasatinib chemotherapeutic drug, tyrosine kinase inhibitor. The good thing about artificial intelligence right now is that we can do a lot of testing in lab and test thousands of compounds and see what they can do individually and in combinations. So individually, the dasatinib doesn't do much as a senolytic. When you combine it with quercetin, a natural supplement, a product plant, a polyphenol, which has I'm sure most of you know what quercetin is. It has antioxidant and SERM-modulating activity. When you combine them both, voila, you have a senolytic. You have a senolytic combination, right? And you have a much safer, lower toxic effects. DQ has many studies, both in vitro and clinically. So this is a combination that has evidence-based published clinical studies, right? So we know what this does when we use them with patients. There's multiple protocols that have been published of the DQ combination, right? One thing that's pretty much common or standard is we're usually doing treatments for short treatments, 3 days. We can cycle, we can do 3 days and repeat after a month, 2 or 3 times. Usually the dasatinib dose is 50 or 100 milligrams, and quercetin is going to be somewhere between 1,000, 1,250 milligrams, okay? And you can actually, it's here, all the protocols are here, but you can actually check that on clinicaltrials.gov and PubMed, everything, it's been published. It's shown benefits, it's shown to clinically reduce senolytic cells, senescent cells. Usually a very safe, well-tolerated approach. So we have DQ. Other than the DQ combo, I'm very optimistic about fisetin, which is a polyphenol, also a sirtuin activator. It's found in higher concentrations in strawberries. And it's also shown a really high and selective capacity for senolytics, right? So after that, therapeutic plasma exchange. That's another modality I want you to know about at least. We're doing this right now in our San Juan office and in our Orlando office. Therapeutic exchange, or TPE, right? So we know for a long time, by the way, just someone tell me how I'm time-wise. Let me know if I need to start going faster, I can go faster. That's not a problem. As I get older, I talk more, and I need to reverse that a bit, right? So we know from basic research that there's a concept called parabiosis. Have you guys heard of parabiosis? It's an interesting concept. It's been studied for many decades in Cornell. They did a lot of studies in Stanford. Hold on. There we go. It comes from the Greek para, meaning alongside bios, meaning life. You're basically connecting two organisms. You're connecting two organisms and having their circulatory systems intertwined. So blood from one animal is going to the other animal, and then it's returning to that animal, so they're just connected that way, right? What they found was that when they connected a young mouse with an old mouse, the young mouse provided the old mouse with some growth factors, some youth-enhancing factors, and the old mice started to live longer, right? And so rejuvenation started to occur. That's a concept there. Just connect two people, boom. And the blood of the young rejuvenates the blood of the old, right? So this is a proven technique. Problem is, it's going to be a bit hard to connect people. We're not going to do that, right? But again, what they found from parabiosis is that the youth promoting factors, the ones that we have in our youth, can rejuvenate old tissues, old cells, old organs and tissues. And and vice versa. And they also found that the older factors, what we call the progeric factors, the bad things, can damage the young, can accelerate aging. So it's truly interesting. You know, we have in our blood, we have this highway of, you know, cytokines, growth factors that are just regulating and impacting the aging process all the time. But then, you know, again, because it's not practical, we started looking at plasma-based therapies. So let's say instead of doing blood, and which is again not practical, we started looking at things like therapeutic plasma exchange. Basically, just instead of infusing anything in particular, just taking out a portion of a patient's plasma so as to reduce the progeric factors, with the idea that if you reduce these progeric factors, you can allow the body a rejuvenation process, right? And it's working. We started doing TPE, plasma-based therapies. And in some of the animal studies, the plasma dilution studies worked as well as or even better than the blood-based rejuvenation studies. So some of the researchers started saying, well, is it really that much about, you know, infusing the new, or is it just about taking out the old? So that's where we are with the TPE, right? It's a type of dilution treatment. There are some studies clinically with, you know, using plasma from young donors, and that's still being done. There was a few biotech companies doing that, but that comes with, you know, more risk, more complications. So when we do TPE, we can do just that. We eliminate one or more plasma volume exchanges, and we replenish with plasma albumin plus or minus immunoglobulins, and you're starting to see improvements in epigenetic age, improvements in telomere length, decreased inflammation. You get a lot of things just by doing that dilution. And again, your body starts ramping up production. You eliminate some senescent cells. You allow the body that break so that it can start producing again and repairing, right? So that's where we are with TPE right now. And, you know, we're seeing a lot of growth in terms of clinics starting to offer TPE for aging and age-related diseases. And it also has, TPE, plasmapheresis, has been studied extensively for decades. It has official, indications for certain autoimmune diseases. It has indications for certain malignancies. It has clinical studies showing improvements in Alzheimer's patients. So we see that a lot of things can be impacted. And here you go, plasma dilution can address multiple hallmarks of aging. So when you do the plasma dilution treatments, you can do pre and post measurements, the telomeres, senescent cell burden, epigenetics and such. And you can see after the treatments, you can remeasure and see how these patients are improving. It can also help address immunosenescence, which is again very important. If you guys want to do a very simple lab test in patients, especially in older patients, do a CD4-CD8 ratio. Look at that ratio, CD4-CD8. Simple lab test, anyone can do it. If that ratio in that patient is below less than 1, that patient has immunosenescence. And if that ratio is less than 1, that patient is at an increased risk for mortality within the next 5 years. So that simple test can give you a lot of information about a patient's immune system and overall health, right? And that can also be improved with therapeutic plasma exchange. Inflammatory factors, they go down. We have patients that we do TPE on, the day after, a few days after, they're like, wow, inflammation is gone. I feel so light. I feel a lot better. Because it makes a lot of sense. If they have all these inflammatory proteins just circulating, you just take that away, you're giving them a shot. They're just regenerating, recuperating, feeling a lot better. So we've had some really, really interesting results. One interesting result I recently had, just sharing this with you guys, I had a patient come in. He brought his dad for TPE. his father was like, I think it was like 76 years old, something like that. He had CHF. His ejection fraction was in the 20s. We did TPE. I mean, and granted, the whole idea was not initially to target CHF, but we evaluated him and we did the markers and all that, and he wanted this for the whole benefit. So we did the TPE session, just one session. He lives in the States, so he left. He did it here in Puerto Rico. He left, and about 2.5, 3 months later, his son calls me, and he says, "Doc, my dad went to the cardiologist. His ejection fraction is 40." So that was a really, really pleasant benefit that we saw associated to the TPE. Obviously, we optimized a couple of things, nutrients. We did a few things, but pre and post TPE, his ejection fraction increased dramatically. And he had had CHF for many years now. Another thing I wanted to talk about, exosomes, right? And I've been asked a lot of times, I know a lot of you are wondering, why aren't we doing CME activities, right? Why aren't these conferences CME? They may be. We might do in the future some of the things. But the balance with CME is that from a regulatory perspective, it becomes a lot more challenging to provide you with information that you may use or need in your clinics, right? So, and again, exosomes is sort of like a hot term. FDA doesn't like that term much. We can call them, MSC nanoparticles, extracellular vesicles. But again, you can call it potato, but it's the same thing. Why do we use exosomes, or why do we look at incorporating exosomes for regenerative medicine? So we know that aging causes a decline in stem cells. As we grow older, our stem cells numbers go down. Our growth factors go down. Our regenerative capacity goes down. When I do PRP on a 35-year-old male patient and I inject his knee with PRP, the response is a lot faster than when I do that in a 75-year-old patient. Why? Because of the growth factors, because of the stem cells, because the capacity has gone down. So here is where we can look at other things to add to our therapeutic options. Here's where exosomes come in. Have any of you heard of exosomes already? Some of you have? Okay. So what are exosomes? They are extracellular vesicles. They're basically, to be honest with you, they're produced by all types of cells, and mesenchymal stem cells produce them. And when we use exosomes for regenerative purposes, we're using exosomes derived from stem cells, right? They're basically the good stuff that these cells produce, and that it's full of multiple factors that are, useful regeneratively. They're currently not FDA approved. Okay, so that's important to highlight. They may, I've been talking to a few people in the field that some of them work with some of the labs. They may get, at least one of the companies may get FDA approval this year or next year or so, because they applied for they were pretty smart. They applied for certain uses in long COVID. So they may get an approval there, and then obviously once you get a product approved, then off-label becomes the norm, and you can use it for other options there, right? So anyway, the exosomes, they have nucleic acids, lipids, they have growth factors, they have a lot of proteins, they have a lot of things. 80 to 90% of the benefits of stem cells come from what they release. If you look at the studies with stem cells, administered injection directly or IV or etc., engraftment is usually minimal. So how are these cells really improving repair? They're releasing all these exosomes, all these particles. Exosomes can be sourced from basically everywhere in the body. Cells produce exosomes. So, you can get them anywhere. But what we're doing now is, so we have obviously some of these labs that grow these stem cells, and they can harvest that standardized product and then present it, offer it for injection, right? And again, we know that in the stem cell field, we have a lot of challenges. The FDA right now prohibits physicians from using culture expanded cells and injecting them into a patient, because they call that a drug. So if you have your own, you can have your own stem cells grown in a lab, but you cannot inject them legally because the FDA says no. If you grow them, that's a drug. You'd have to go through the drug approval process. So there's different ways that we can approach this. And again, most of the benefits that are attributed to stem cells are really exosomes and their content. And we've seen this in multiple rejuvenation models. We saw that in parabiosis, we see this in TPE, and blood-based therapies. It's all about the growth factors. It's all about that, right? We have, in these products, we have a lot of different growth factor concentrations. And all these growth factors do a lot of different things, right? From stimulating cell mitosis to recruiting stem cells to the microenvironment to increasing function like neuronal BDNF, brain-derived neurotrophic factor. So we have a lot of growth factors that are available in these preparations, right? So one of the benefits of using exosomes, it's an off-the-shelf product. Usually they come ready to administer, so no complicated preparation. You can have, usually it's standardized, the way the particle counts, we usually talk about billions of particles per dose. You have, if you're treating patients, especially again, older patients, unsure of how their PRP is, growth factor content, etc. You know that when you use something that's a bit more standardized, you probably have a better chance of achieving benefits with these patients, right? And again, you can call them extracellular vesicles, MSC nanoparticles. They have a lot of applications, right? They're being used in regenerative aesthetics, right? Alopecia, collagen stimulation with microneedling, ECM formation. They're being used in ortho-MSK, intraarticular injections, soft tissue injections. They're being used for frailty aging, IV infusions, and chronic debilitating diseases, long COVID, CFS, and others. So again, there's multiple benefits here that we could see with exosome administration. I've treated many patients with these products, and I've seen clinical benefits. And it's probably still on the newer side, so we're still gathering data, and there's still going to be published studies and more published studies. But I'm pretty confident that we're going to get at some point the FDA approval for at least for one of the products. Right? On the horizon, and we're done with this. I'm finished. Well, on the horizon, what's coming next, right? Anyone that knows me knows that I'm always looking for what's coming. What's the future like, right? So we're going to have, there's works right now on gene-based therapies for longevity, cellular reprogramming, tissue and organ engineering. I mean, the near future it may look a little like a sci-fi movie, You may at some point need a replacement liver, and you'll have a company just grow your hepatic stem cells in a lab and then call the surgeon, hey, just switch the liver, put a new liver into his body. I mean, that's where we're heading right now. And it's not that far away. Honestly, it's not. So we have a lot of things. We have a lot of biotech companies in the field. And when critics say anti-aging medicine, that's witchcraft, that's blah, blah, blah. It doesn't work. I just tell them, listen, IBM, Google, Microsoft, Jeff Bezos, Mark Zuckerberg, Elon Musk, they're all putting billions of dollars into longevity and anti-aging medicine. There's a reason why. And, you as physicians should be on that cutting edge. You should know all about this. You should know about these therapies, and you should try to implement this as much as possible. And, obviously as a group, we can do a lot more together. So that's also very important. And, just remember something. And I think, I'm not sure, but I think maybe Ray Kurzweil said this, or someone said this. Technology is reaching that critical point. And I think we're really reaching it because now we have this whole artificial intelligence going wild, ChatGPT, probably Skynet at some point, if you remember Terminator. But we're reaching that point where we go to that escape velocity, where the technology will evolve so fast that we'll get to that singularity. So I really say this, and I believe this. Just live long enough to live forever. If you live long enough to live for the upcoming technological advancements, you might just be able to live a lot longer than you expected. Okay? So just remember that I appreciate your time. I know it was the last talk. And if there's any questions, I'm more than happy to entertain them. Thank you.